outcome measures in neural rehabilitation. This webinar comes to you as part of a series of webinars. It's called the Just-CRS Professional Training Program. This activity is part of the Just-CRS Clinical Rehabilitation Sciences Masters Program, which is a project co-funded by the Erasmus Plus program of the European Union. And we are thankful and so happy to have Dr. Ala Jaber present this webinar. I just want to also share with you that this webinar comes to you as a courtesy of Maharat platform. This is a new electronic platform coming from the Electronic and E-Learning Center at Jordan University of Science and Technology, which is the grant holder of the project. And we are happy to share all this knowledge with you during this time of isolation. So stay home, stay safe, and come and watch our seminars. Okay, I will start. I will give the time to Dr. Ala to introduce himself and start the presentation. If you have any question, please put it in the chat, and we will have some time to answer all these questions. And again, stay tuned in this Maharat platform, because we will put a number of electronic mini courses that you can access and get certificates. At the end of this presentation, there will be a quiz. If you get 70% and more, you will get the certificate mailed to you within 7 to 10 days. So thank you for coming and enjoy. If you can maximize the PowerPoint display, full display.
Yeah, can you assist me in this, Dr. Muhammad? Now, can you see me now? Or?
Yes, perfect.
All right, great. So, hi everyone. I would like to welcome you all in this Just-CRS Professional Training webinar number 5. And the topic of our presentation today, as Dr. Muhammad Nazal said, is outcome measures in neurorehabilitation. So I'm going to be your presenter. My name is Ala Jaber. I'm an assistant professor of occupational therapy in the Department of Rehabilitation Sciences at JUST. In this session or webinar, we're going to cover different learning objectives. First, we're going to talk about health outcomes and outcome measures. Then we're going to discuss and introduce different psychometric properties of outcome measures, including validity, reliability, and responsiveness to change. Then we're going to discuss the steps of translation and cross-cultural validation of outcome measures. Finally, we're going to review the functional independence measure as an example of standardized outcome measures that has been validated through research. So first of all, what are health outcomes? Health outcomes are defined by the World Health Organization as change in the health status of an individual, group, or population, which is attributed to a planned intervention. Examples of health outcomes include cognitive functions, motor skills, and quality of life. So health outcomes are assessed using outcome measures. Outcome measures can be instruments, can be questionnaires, scales, or tools that are used to objectively measure or assess changes in health status. Examples of outcome measures include the Mini-Mental State Examination to assess cognitive functions, and the Glasgow Coma Scale to assess the severity of acute brain injuries. Outcome measures are very important for both clinicians and researchers, as it helps us assess changes in health status and track progress. Choosing a health outcome or an appropriate health outcome is very important, and there are many factors that may affect our choice or selection of an outcome measures, including the population of interest. So for example, are we interested in assessing a population of patients who have a specific health condition like stroke or Parkinson's disease? Or are we interested more in assessing individuals who do not have health conditions like healthy controls? The variable to be assessed or evaluated is also important. So for example, if I'm interested in assessing cognitive function or motor skills, I would choose an outcome measure that assesses the exact skill or health outcome I'm interested in evaluating. The place of administration is another factor that we must consider. For example, if I'm a clinician who work in a hospital or in a clinic, I must choose or select an appropriate health outcome to be used in my setting. And time and frequency of administration. So different health outcomes may have different times of administration or frequencies of administration. For example, some instruments may be more appropriate to be administered upon admission to acute care or inpatient rehabilitation or at discharge. And for the frequency of administration, some instruments can be used once to collect data or assess health outcomes, whereas others can be administered multiple times. The method of administration can vary between health outcomes. For example, some health outcomes or outcome measures, can be administered through an interview, whereas other outcome measures can be done using a tool, for example, like using a goniometer or a dynamometer. The practicality of use is the last factor that we're gonna discuss. The practicality of use is very important as well, because some outcome measures are available for free for all of us, and some outcome measures require specific training in order to be qualified to use the outcome measures. So amongst the wide variety of outcome measures, we have to consider all of these factors in order to choose the appropriate outcome measure for use in clinics or in research. In order to choose appropriate outcome measures, we have also to consider the quality of these instruments or outcome measures. Because if we choose standardized assessments that have been validated through research, then it's most likely will produce accurate results that will yield interpretable data, which will result in more robust scientific results about health outcomes. Now we're going to talk a little bit about the psychometric properties of outcome measures. So the psychometric properties of outcome measures are the reliability of instruments, validity, sensitivity, specificity, and responsiveness to change. So the first property is reliability. Reliability is the degree of consistency of a measure, which means that what is the degree of consistency in the results that an instrument can produce. Would it produce similar results or not? If it's a reliable instrument, it will yield or produce similar results each time we use it, and no matter who uses it. For example, if different raters use it and the instrument is reliable, it will probably yield similar results. Reliability coefficients is the unit of measurement for reliability. It can range between 0 and 1, with reliability coefficients closer to 1 being more desirable. And reliability coefficients have been categorized into different levels based off of the value of the reliability coefficient. For example, a reliability coefficient of 0.9 or more is considered to be excellent reliability for the outcome measure that achieves this value, whereas outcome measures that have a reliability coefficient of 0.5 or less are considered poor and unacceptable. There are three factors that affect reliability, which include the function or the purpose of the instrument itself, the population among which the instrument is used to assess, the circumstances of assessment, and if these factors change for some reason, then the instrument might not be reliable anymore. For example, if we test reliability for an instrument on individuals with stroke, and the test or this outcome measure proves to be reliable, then that's excellent. So if I choose to use the same instrument to assess or to evaluate the same health outcome among individuals with Alzheimer's disease, because the population is different, the disease itself have a different prognosis and pathology, the instrument that was proven to be reliable among individuals with stroke not necessarily be reliable when the population change, and in this case among individuals with Alzheimer's disease. So if we change the population or any of these factors, we have to reconsider or reassess reliability for the outcome measure. There are four major types of reliability, which are raters reliability, test-retest reliability, parallel forms reliability, and internal consistency. These are the four major types of reliability, and the raters reliability is divided into two sub-categories, which are inter-rater reliability and intra-rater reliability. So the first type of raters reliability is the inter-rater reliability. The inter-rater reliability is the degree to which two or more raters are able to get similar results consistently whenever they use the same instrument. So in this type of reliability, there is multiple evaluators or more than one individual who uses the same instrument. If this instrument is used within the same conditions by two different evaluators or two different observers or two different assessors, the results should yield similar results, or the results should be similar if this instrument has good inter-rater reliability. And the unit of evaluation for inter-rater reliability depends on the type of questions that the instrument or the questionnaire has. For example, in the cases of categorical variables, which means that the response or the answers are yes/no questions, or it could be gender, for example, male and female. So these are considered categorical variables. In this case, we use the kappa value to represent the reliability coefficient. The kappa value is the percent of agreement between two raters. So for example, if two raters use the same instrument, and the instrument has 10 questions, and each question has a yes/no answer. So if the degree of agreement between them, for example, it was 90%, like both of them got 9 questions correct with the correct similar response, then the kappa value would be 90%. In cases of continuous variables or numerical variables, such as age or BMI, for example, we use intra-class correlation coefficients, which measures the correlation or association between two numerical variables. The inter-rater reliability sometimes can be the correlation coefficient or reliability coefficient, excuse me, if the reliability coefficient for inter-rater reliability yields insignificant correlations between both assessors' results, then it can be improved by training the raters about the administration of the instrument being developed, or ensuring that the categories or the questions are clearly defined or objectively defined to reduce raters' subjectivity. The second type of raters reliability is the intra-rater reliability. In cases of intra-rater reliability, we have one assessor or one evaluator or one observer who does multiple evaluations. The multiple evaluations done by the same rater will yield similar results if the instrument has high intra-rater reliability. And the unit of evaluation is similar to those that we have just discussed in the inter-rater reliability. We use kappa values for categorical variables, and we use intra-class correlations for numerical or continuous variables. The second major type of reliability is the test-retest reliability. The test-retest reliability relies mostly on time. So it's multiple evaluations done using the same measure but at different times. So we have also to make sure that the same subjects or same circumstances are done or are used while performing test-retest reliability. Test-retest reliability is the most common type of reliability, and the unit of evaluation is the reliability coefficient between the different measurements which were conducted at different times. The parallel forms reliability is also known as equivalent or alternate forms reliability. This type of reliability is tested for instruments or forms that have different versions of the same instrument. For example, the Montreal Cognitive Assessment is an outcome measure that is used to assess cognitive functions on 8 domains of cognition, and some of the items within the same form have been switched in order to avoid the learning effect or recall bias, because sometimes, let me show you the assessment forms. So here we see 2 different versions of the same assessment. However, if we look at the naming scale or naming question, which has the pictures, so if you look at the 2 different forms, you see that there is a lion, rhinoceros, and a camel in the first evaluation form, whereas in the second form, we have a horse, a tiger, and a duck. So the pictures have been switched in order to avoid recall bias, and both forms evaluate the same health outcomes. However, the pictures were changed in order to avoid the recall bias. And the unit of evaluation for parallel forms reliability is the correlation coefficients of both forms. So for example, if we use the form on the left for the one individual, and we use the form on the right for the same individual, they should both yield similar results that are highly correlated. The last type of reliability is internal consistency within a test. Internal consistency as a type of reliability means the degree at which all items of a test measure the same construct. So a test with high internal consistency, we will discover, or we will find, that all items within the instrument itself are highly correlated with each other and with the total score. And there are 2 different techniques for testing internal consistency. The first method is split half, and the second method is Cronbach alpha. For the first method, we divide the items within the whole instrument into 2 halves. Then we measure the correlation between the 2 halves. It should be highly correlated if the instrument has high internal consistency. The second method is Cronbach alpha, and this method uses an average correlation for all possible combinations of split halves. So for example, in this picture to the right side of the slide, right bottom side, we see that the items were split into two halves, and the first half has items 1, 3, and 4, whereas the second has 2, 5, and 6. So that's one possible combination. Another possible combination would be, for example, 1, 2, 3 with 4, 5, 6. So in Cronbach alpha, in the case of Cronbach alpha, all possible combinations are tested in a split half style, and then the average correlations are measured in order to establish internal consistency. If the average correlations between all possible combinations is high, then the instrument has high internal consistency. Now we're going to talk about validity, which is the second psychometric property of instruments. Validity is the ability of the instrument to exactly measure what it is supposed to be measuring. For example, if I want to measure weight, then I would probably use a scale. I will not use a tape measure. Or if I want to measure, for example, a range of motion, the range of motion for the elbow joint, for example, I would use a goniometer. I will not use a dynamometer. So an instrument is valid if it really measures what it is supposed to measure. And validity is arguably the most important psychometric property for the quality of any test. There are 4 major types of validity. The first type is phase validity. The second type is content validity. The third is construct, and the fourth is criterion-related validity. The third and fourth types are have subcategories. So, for example, for construct validity, it is divided into convergent validity and discriminant validity. And the last type, criterion-related validity, is divided into concurrent and predictive validity. The first type of validity is phase validity. In cases of phase validity, does the instrument appear to measure what it is supposed to measure just by appearance? For example, if I look at an instrument that is supposed to evaluate quality of life, if I read all the items within this instrument, then if it has phase validity, then I'm able to decide based off of the relevance from the perspective of participants who will complete this test. So if all items appear to measure the construct or the health outcome in question, then it has phase validity. Phase validity is the least rigorous method for documenting a test or a validity of any outcome measure, and it's not sufficient by itself to establish validity for outcome measures. The second type is content validity. So in cases of content validity, does all items within the instrument itself adequately define the variable or the health outcome I am aiming to test? So content validity is very important, and it's evaluated. The method of evaluation is both qualitative and quantitative. So the qualitative piece of assessing content validity is by the selection of an expert panel of 6 to 10 experts in the field. So for example, if I want to assess depression, for example, I would choose 6 to 10 experts in the field of depression. Then I would send them a copy of the depression questionnaire or depression inventory, and I would ask them to give suggestions or give their opinion or any notes about the phrasing of the items or phrasing of the instructions, which are necessary for the implementation of this evaluation. Then the quantitative approach for content validity is done using or calculating the content validity index. The content validity index measures the proportion or percentage of experts who agree on the relevance of item, which are scored on a scale of 1 to 4, in which 1 means a non-relevant item, whereas 4 means a totally relevant item. So assuming that we have an outcome measure with 10 items, and one of the experts scored these items, and we need at least a score of 3 or 4 for each item in order to be sufficient or to be considered as an acceptable score. And in order to calculate the content validity index, we divide the number of answers who got, or the number of items that got 3 or 4 on the total number of answers. So for example, those 10 items, let's assume that 8 of them got a score of 3 or 4. We'll divide it by the total number of items, which is 10 items, and we'll get 80% content validity index. An 80 to 90% content validity index is considered sufficient to establish content validity for an outcome measure. Construct validity is the third major type of validity. It is the degree at which a group of variables really represent a construct to be measured. So in the cases of construct validity, all of the variables or all of the items should measure or should be representative of the construct being evaluated. And the method of evaluation for construct validity is the correlation coefficient between the target outcome, which is being currently developed, and other measures that have already been established to measure the same construct. And as I have indicated earlier, that construct validity is divided or into two subtypes, which are convergent validity and discriminant validity. So in cases of convergent validity, the new item that is being or the new outcome measure, sorry, that is being developed, it should correlate with another item or another outcome measure that has been established to, or that has been known to measure the same construct. For example, if I'm aiming to develop a questionnaire that evaluates quality of life, so I would go, for example, to the World Health Organization quality of life questionnaire. Then I would compare the results that I get from the recently or from the outcome measure that I'm aiming to develop with the results of the World Health Organization quality of life questionnaire, which has already been established and tested through research. If both results of my recently developed questionnaire with the World Health Organization quality of life questionnaire results, if both scores correlate highly, then that means that this confirms that the instrument that I am aiming to develop to test or to evaluate quality of life is highly correlated with a pre-established quality of life questionnaire. This means that, or this confirms for me that the newly developed instrument really tests the construct that I'm aiming to evaluate, which is in this case quality of life. Discriminant validity, on the other hand, which is the second subtype of construct validity, indicates that two different outcome measures which measure different constructs should not be correlated. There should not, I do not expect to find, for example, a correlation between an outcome measure that evaluates cognitive skills with an outcome measure that evaluates motor skills, because these are two different health outcomes. So, for example, to give an example, if I compare the results of an intelligence test, like an IQ test, with another outcome measure that evaluates gross motor skills, then I expect that the results will not be correlated together, because these outcome measures measure two completely different health outcomes. So the first one confirms that, which is convergent validity, that my newly developed outcome measure really measures the health outcome when I compare it, or when I correlate it with a pre-established outcome measure that measures the same construct. Whereas discriminant validity tells me that my outcome measure, newly developed outcome measure, does not correlate with another outcome measure that measures another completely different construct. The last type of validity is criterion-related validity. Criterion-related validity indicates that the developed instrument can be used as a substitute of a measure for an established standardized test. So how do we establish criterion validity? By comparing the results of our newly developed outcome measure with a gold standard that has already been identified to measure the health outcome of interest. For example, the functional independence measure or the Barthel index are some of the gold standard instruments that use independence in activities of daily living. So let's assume that I want to evaluate the criterion validity for a newly developed outcome measure that evaluates independence in activities of daily living. So I bring my newly developed outcome measure, and do the assessment or evaluation. Then I compare it with the results of the functional independence measure. If they are completely, or if they are highly correlated, that means that I have established criterion-related validity, and I can use my newly developed outcome measure to substitute for the gold standard, which measures the same health outcome. Sometimes establishing criterion-related validity can be challenging for researchers, because not all health outcomes have a gold standard to be compared with. So we have to take this into consideration, because sometimes whenever we search for the psychometric properties for some research instrument or for clinical tools, we find that not all psychometric properties have been tested, and this is, for example, why criterion-related validity sometimes could not be tested if there is no gold standard for my newly developed outcome measure to be compared with. Criterion-related validity can be subdivided into two types: concurrent validity and predictive validity. And it all depends on the time of administration of both outcome measures, the newly developed outcome measures and excuse me, and the gold standard. So for example, I said, I gave an example of developing an outcome measure that is aimed or geared toward assessing independence in activities of daily living. And I compared it with a functional independence measure, which is considered a gold standard in this for assessing this health outcome. So if I assess or do both measurements using those two different those two outcome measures, if I do it at the same time and I compare, that's considered concurrent validity. If they were highly correlated, whenever I administer both measurements at the same time and compare them through a correlation analysis, if they're highly correlated, then I have established the concurrent validity for the newly developed outcome measure. Whereas if I use the newly developed outcome measure to predict the gold standard measurement in the future, for example, I administer the newly developed outcome measure right now, and I test the predictive ability of my newly developed outcome measure with the gold standard, which was assessed, for example, 2 weeks later or 1 month later. If I'm able to establish the predictive ability of the newly developed outcome measure, then I can say that we can confirm that predictive validity is established for that outcome measure. The method of evaluation for criterion-related validity is through the use of correlation coefficients. I said if the newly developed outcome measure is highly correlated with the gold standard, either when both instruments are administered at the same time, which constitutes or represents concurrent validity, or whether we do the correlation analysis to establish the predictive ability of our newly developed outcome measures with the gold standard. A correlation coefficient of 0.7 or above is considered acceptable to establish criterion validity. So let's look at this figure, which helps us identify how validity and reliability interplay together. So for example, in the first image below, we can see that the cluster of responses is way off the center. Way off the center, that means it's not valid, but it's reliable because they are closely stacked together. And let's refer to the note in this slide, which says that validity evaluates the accuracy of a measure, whereas reliability evaluates the consistency of results for any given measure. So in the first image, or in the first circle to the bottom left of this slide, we can see that the item or the instrument or the outcome measure is reliable but not valid. Reliable because every time I use this instrument, I get similar results, and that's indicated by the close grouping of results on the image. Whereas it's not valid because it does not evaluate, it's not accurate, it does not evaluate all aspect of the construct that it is intended to evaluate. The second image represents a valid but not reliable outcome measure. Valid because it evaluates all components or all aspects of the outcome in question, but not reliable because they are widely spread. So each time I use this instrument, I get different results. It could be at the bottom left, for example, or it could be at the top right. So the widespread or inconsistency in results indicates that the instrument is not reliable. For the third circle, we can see that the instrument or the outcome measure is neither reliable nor valid. Neither reliable nor valid because it's not valid, first of all, because it does not assess all aspects of the construct or the health outcome in question, and not reliable because the grouping is widely spread as well. The last image to the bottom right side of this slide shows us an outcome measure that yields both valid and reliable results. It is accurate, it yields accurate results, which means it's valid, and it yields similar results every time I use this outcome measure, which means it is reliable. We're going to talk about other psychometric properties of outcome measures, which include sensitivity, specificity, responsiveness to change. So sensitivity and specificity are some of the properties that are established for screening tools mostly, which helps us identify or diagnose some of the health conditions, such as depression or dementia, for example. Sensitivity means that the instrument is able to correctly assess or identify those who actually have the disease, which yields, or in other words, helps us identify individuals who have a true positive results for the disorder that is being evaluated or assessed. Whereas specificity is the ability of the assessment tool to correctly rule out those who do not have the disease, or in other terms, those who have a true negative results for not having the disorder in question. Examples of outcome measures that we can test sensitivity and specificity for include the PEC depression inventory for evaluating depression, and the dementia rating scale for assessing mild cognitive impairment or dementia among individuals with Alzheimer's disease. So the last criteria in the psychometric properties we're going to discuss today is responsiveness to change. So responsiveness to change is the instrument's ability to detect minimal change over time. Why is detecting change important? Because it can represent actual changes in the health status or health outcome of individuals. Using the responsiveness to change criteria, we are able to identify the minimal clinically important difference, which is the smallest difference that is measured and it is that represents minor or even the least trivial changes in the patient condition. The minimal clinically important difference is the least score or the least change in the health status of an individual that is clinically meaningful, that's clinically important. And who decides if it's clinically important or meaningful? It's the client's or therapist's perceptions about what is considered improvement. Now we're gonna talk about translation of outcome measures, translation and cross-validation of outcome measures. So any outcome measure can be translated into different languages. So for example, the functional independence measure has been translated into French, German, Japanese, and Swedish languages. Sometimes with translation comes also cross-cultural validation, because what constitutes cultural norms in one nation or that has a different language is not similar or is different from another culture that lives, for example, in another region of the world and speaks a different language. Excuse me for the stacked slide in this about steps of translation, but I included a lot of details for any of our attendants who is who are interested in translating outcome measures into a different language. So steps of translation are 5 steps. The first step is to do a forward translation. Let's assume that we have the functional independence measure, which was established or made in English language. Let's assume that we want to translate the functional independence measure into Arabic. So the original language would be English, and the desired language would be Arabic. So to perform forward translation, we have to get 2 independent bilingual translators to produce 2 translated versions. One of the translators should be knowledgeable about the topic of an instrument. For example, an occupational therapist could be one of the translators, forward translation translators, and another individual who is not knowledgeable about the health outcome or the outcome measure that is being translated. It's important to emphasize that the mother tongue of both translators should be Arabic, which is the desired language of translation. Then the second step is synthesis 1, a comparison of the true translated versions is done by a third bilingual independent translator regarding the ambiguity and discrepancies of wording, sentences, and meaning. So first we did a forward translation by 2 independent translators whose mother tongue is Arabic. Then in the second step, synthesis, the 2 versions that have been translated to Arabic must be compared for clarity of wording by a third independent translator whose mother tongue is Arabic as well. Then after that, we do a backward translation. The backward translation, the Arabic translated instrument is translated back to English by 2 independent translators, one of which is an expert in the field, and the other one is not an expert. It's important to emphasize that the mother tongue of translators should be English in this case, but they know Arabic very well, or they can speak Arabic. They're bilingual, and it's important to also blind the backward translators from the original English version that is currently being translated to Arabic. Then the fourth step is synthesis 2. We compare the 2 backward or back translated versions by a multidisciplinary committee for clarity of instructions, items, and responses in terms of wording, meaning, and relevance. And the committee should include a methodologist, a health professional, and all 4 translators who participated in the forward and backward translation, or any discrepancies or any ambiguities about wording or instructions should be resolved or corrected by the committee. And that this step produces a final version of the translated instrument. The fifth and last step is to do pilot testing, or in other terms, cognitive debriefing about the translated instrument. So we have to do like pilot testing. We have to test the translated version of the instrument. And this is done on 2 steps. First of all, evaluation by a sample of 10 to 40 participants who are native Arabic speakers. The sample should be participants who are monolingual, so they only speak Arabic language, and each participant is asked to rate the items on a scale, a dichotomous scale, which means either 0 or 1 or clear or unclear. Then they're asked to provide suggestions about unclear instructions or unclear items. What do they think that, what are their suggestions to make unclear items or unclear instructions, how to make them clear. And a minimum of 80% agreement on clarity among all participants in this pilot testing is required in order to consider this as a successful pilot among the sample of participants. Excuse me. Then the second step of pilot testing is done through an expert panel of 60 individual experts in the field of the instrument. So, for example, we bring, let's say, 3 occupational therapists and 3 physical therapists, and we ask them to evaluate the items on clarity as well, and a minimum of 80% agreement is needed. Then to establish content validity, the panel also rates the items for relevance on a scale of 1 to 4. If you remember when we talked about content validity, we talked about a content validity index, which is the division of number of items that got a score of 3 to 4 on relevance on the total number of items in the instrument, and a minimum of 0.78 content validity index and an average of 0.9 content validity average is desired to consider the newly developed or the translated questionnaire to be valid and ready for use. Now, we're going to talk about an example of an outcome measure, the examples of outcome measures that are used in neurorehabilitation. So outcome measures are various and can be administered at different stages of medical management or rehabilitation of individuals with neurological conditions. I selected stroke as an example of neurological conditions that is common among older adults. And examples of outcome measures that are used in stroke rehabilitation include the Bartle Index, which is an outcome measure that is used to measure independence. It's a short questionnaire that evaluates independence or ability to perform activities of daily living. It's a short questionnaire. It can be administered during inpatient rehabilitation of individuals with stroke. Another instrument is the Community Integration Questionnaire, which evaluates the individual's capacity and performance whenever they go back to their communities after rehabilitation. The third instrument is the Glasgow Outcome Scale and the National Institute of Health Stroke Scale. So National Institute of Health Stroke Scale is an instrument that is used to assess stroke severity. It can be used during acute medical management and inpatient rehabilitation of individuals with stroke. And this instrument can be administered like multiple times in order to assess individuals with stroke to see how severe is the stroke episode that they had and what are the consequences of the stroke that they had on their motor skills, for example. The functional independence measure is an outcome measure that evaluates independence and functional capacity in performance of activities of daily living. We're going to talk about it in more details in the next slides. In the next slides, the Canadian Occupational Performance Measure is a client-centered outcome measure that evaluates perceived challenges in daily activities for individuals with stroke. It has been validated with more than one population. It has been used with individuals with other health conditions, but it was validated with individuals who have stroke. And the last questionnaire or outcome measure is the stroke-specific quality of life measure. This is a quality of life questionnaire that has been developed for use specifically with individuals who have stroke. And if you remember, well, when we talked about reliability, we said that multiple factors affect the reliability of outcome measures, and multiple factors affect our choice of outcome measures. So we can clearly see here that some outcome measures are specifically developed for target populations, such as this stroke-specific quality of life questionnaire. And this is, of course, it evaluates the quality of life outcome for individuals with stroke. Now we're going to talk about the functional independence measure as an example of outcome measures that have been validated through research. So what is the functional independence measure? It's an outcome measure that evaluates the level of independence and functional performance of activities of daily living. So it evaluates our ability to perform daily activities by ourselves. Can we do it independently, or do we need any assistance? It has been validated for different populations, including individuals with stroke, individuals with traumatic brain injuries, individuals with spinal cord injuries, and individuals with multiple sclerosis. This is considered an assessment tool as a type of outcome measures, and it has 18 items. It has two subscales, which is the motor FIM subscale and the cognitive FIM subscale. The motor FIM has 13 items, which evaluates our ability to dress, feed, go upstairs, or perform other tasks that involve mobility, for example. And there are 5 cognitive items in cognitive FIM subscale, which assess cognitive skills such as communication and memory. Each item is scored on a scale of 1 to 7, in which 7 means completely able to perform this activity or this item completely independent without any assistance, and 1 meaning that the individual that is unable to perform this activity and is completely dependent in the performance of that specific activity. The total maximum score of FIM is 126, and the range is 18 to 126. So the least score anyone can get on FIM is 18, because the rating scale starts with a 1 to 7. The time of administration is almost 45 minutes, and it's done through an interview. Raters can be health professionals with FIM training. So yes, this instrument requires specialized training in order to be able to perform or administer this outcome measure successfully and accurately. If you remember, when we talked about the selection or choice of outcome measures, we said that the feasibility or circumstances of assessment is important. And this instrument, for example, it's a great instrument and for assessing independence and for use in neurorehabilitation for individuals with neurological conditions, although it requires specialized training for accurate administration. This is a copy, or this is a shows us the functional independence measure. To the bottom left side of the screen, we can see that each FIM item is administered on a scale of 1 to 7, with 1 requiring total assistance, and the individual is completely dependent, unable to perform this task, and 7 denoting complete independence and successful administration within an acceptable time and in a safe manner. Functional independence measure can be administered during multiple stages of rehabilitation of individuals with stroke. It can be performed upon admission to inpatient rehabilitation and upon discharge. We can compare the scores in order to calculate change. If you remember, we talked about responsiveness to change. And responsiveness to change helps us identify if these individuals have actually improved or have actually and significantly improved. This is reflected upon the scores that we get in discharge, and we can set a minimum score for the individual to be eligible for discharge. We can also do a third evaluation, let's say after a month or 2 of discharge from inpatient rehabilitation, to see how the individual is doing in his community or at home environment. The psychometric properties of FIM have been tested and validated through research. It has excellent scores. So first of all, we're going to talk about reliability, for example. The first type we said is rater's reliability, which is divided into inter-rater reliability and intra-rater reliability. The intra-rater reliability was found to be 0.98, 0.98 and 0.95 for the motor subscale, the cognitive subscale, and the total FIM subscale, which is excellent. That's the intra-class correlation coefficient, which is excellent. As I said, as we indicated, that a reliability coefficient of 0.9 or more is considered excellent. For the inter-rater reliability, which is different from the intra-rater, the intra-rater, we said that there is one evaluator who does the evaluation multiple times, whereas in the inter-rater, we have 2 or more evaluators that evaluate the same subjects or same participants, but they do it like the measurements are done by 2 or more different raters. So the intra-class correlation coefficient for the inter-rater reliability is also high at 0.96 for total FIM. The test-retest reliability, which is just to remind myself and all of you, is that the measurements are done at different times. So time is of essence in evaluating test-retest reliability. And whenever different assessments are at different times are done, they found that the intra-class correlation coefficients for FIM were 0.93 for total FIM. Why do I say total FIM? Because some studies report the subscores or for the motor FIM and the cognitive FIM, and some of them report excuse me, report the reliability for the total score. The last type is internal consistency with a Cronbach alpha of 0.88. Internal consistency means that all items are correlated together, or they do correlate together. And if you remember, or if I would like to remind myself and everyone that internal consistency as a type of reliability is established either using split halves method or Cronbach alpha. In cases of Cronbach alpha, it is reporting the average correlations for all possible split halves for items within the instrument. And the Cronbach alpha, which is the internal consistency reliability coefficient, was 0.88 at admission and 0.91 at discharge, which are also considered good to excellent. So the psychometric properties for FIM also include validity. Validity was tested for the functional independence measure. First of all, the content validity was established. The content validity was established the content validity is established by calculating the content validity index. So it was tested for face and content validity, and it was established to have a good content validity by an expert opinion or an expert panel. The construct validity, both convergent and discriminant validities have also been established for FIM. So the total FIM score and the motor subscale were correlated strongly with the survey of disability scale, survey's disability scale, and it yielded a correlation coefficient of 0.8 with the total score of FIM and 0.84 with the motor subscale, which is considered a good reliability. The discriminant validity, convergent validity, just to remind myself and everyone, is that when we compare the newly developed instrument with another instrument that measures the same construct, it should be highly correlated. And this was proven to be true when we compare the FIM total scores with and motor subscale with the survey's disability scale, which measure the same construct, and it was highly correlated at 0.8 with the total score and 0.84 with the FIM motor subscale. The discriminant validity, on the other hand, it should yield insignificant results or insignificant correlations whenever we compare our newly developed outcome with another outcome measure that measures a different construct. And this was the case when FIM, total FIM and motor FIM subscale were compared with the Wechsler verbal IQ test. It was not correlated. There was a weak correlation at 0.35 with the total FIM score and 0.27 with the motor FIM subscale. The criterion validity was established also for FIM, and the FIM was compared with the Barthel index, which also measures independence and performance of activities of daily living, and they were highly correlated. FIM and Barthel index, I mean, at Spearman correlation of 0.92 and intra-class correlations of 0.86. So in concurrent validity, both measurements are done at the same time, and they're compared for in means of correlation. Are they associated with each other or not? In cases of predictive validity, we said that the newly developed outcome measure, which is in this case, for example, is FIM, is able to predict gold standard in the future. And FIM did predict the physical care needs of patients with stroke, and so it has predictive validity. Finally, we're going to talk about FIM minimal clinically important difference. So this goes in line with responsiveness to change, and a researcher, Benignato et al. 2006, conducted a study to define the minimal clinically important difference for FIM. He recruited like 116 stroke survivors, and he found that FIM scores which were associated with minimal clinically important difference were 22, a change of 22 on the total FIM score, a change of 17 points on the motor subscale, and a change of 3 points on the cognitive FIM subscale, in order to say that individuals with stroke really improved in a manner that it can be clinically meaningful, and it reflects on their performance. These are the references for today's lecture. Thank you so much for listening, and if you have any questions. Dr. Muhammad?
Thank you, Dr. Ala Jaber, for your interesting presentation. There are some questions, though.
Sure.
From the audience.
Yeah.
Okay. So can you, Sonny, I don't know, can you please give us more examples about content validity?
Yeah. Content validity. So content validity, as I said, it is used to establish that the items within instrument or a tool actually measure the health outcome that the instrument should evaluate. And to establish content validity, we must recruit an expert panel of 6 to 10 individuals, and they have to assess the clarity of items, clarity of instructions, and let me put on it, put the slides for content validity. Yeah, so it must be, content validity must be established by an expert panel, as I said, of 6 to 10 individual experts in the field. And they must come into an agreement of at least 80 to 90% on relevance of the items within the instrument. Any instrument that is deemed or that is scored by the expert panel as non-relevant or needs extensive revisions must be either removed or revised, but it cannot stay, because it affects the content validity index score. And as I said, we need at least 80 to 90% content validity index in order to say that the instrument has good content validity.
Okay. I don't know, Abir is asking about the chart, reliability and validity. Can you talk about it again?
Sure. Yeah, so this is the chart, yeah. As I said, validity is about the accuracy of a measure. It measures what it is supposed to measure. In this first image to the bottom left side corner of the slide, we see that the responses did not evaluate all components or all aspects that the outcome measure is supposed to evaluate. So accuracy, we're aiming to be accurate and straight to the point and try to aim for the middle of this. Let's assume that it's a dartboard. We're aiming to be accurate and hit the center. Let's assume that the center is the construct or the all aspects of the health outcome construct we are aiming to evaluate. So we see that it's way off the center, and thus it's not accurate, it's not valid, but it's reliable, because each time we use the instrument or the outcome measure, it yields similar results. So it is consistent about giving similar results, but it is way off the center. It's not accurate. Hence, it's reliable but not valid. In the second image, it's valid. The instrument or the outcome measure is valid but not reliable. Valid because it assesses all components or aspects of the construct, but it's the results are widespread. Widespread, that means each time I conduct or measure or use this outcome measure, it gives me different results. It could be at the bottom, it could be at the top, it could be at the right or the left. So there's no consistency in the results that it yields, and hence it's valid but not reliable. The third image or the third dartboard, let's say, it's neither valid nor reliable. Not valid because it does not measure all aspects or all components of the construct that I'm aiming to evaluate, and at the same time it's not reliable because each time it gives me a different result, and hence it's deemed neither reliable nor valid. The last one, or the last dartboard on the bottom right, is considered both reliable and valid because it's accurate and hence valid, and it's reliable because it yields consistent result each time we use this outcome measure. Hope this answers your question.
Thank you so much. So you know, psychometric properties, validity and reliability is very important for researchers, and my question is about clinicians. Why should clinicians know about this? If clinicians know how to administer tests, but why it's important to know about validity, reliability, and the things that maybe makes errors of validity and reliability from a clinician point of view?
Sure. So both clinicians and researchers use health outcomes, either in clinics, like for example the functional independence measure, and as I said that outcome measures can be questionnaires and they can be tools as well. So for example, we use the dynamometer to evaluate grip strength, and we use the goniometer to evaluate range of motion, for example. We use the aesthesiometer to measure 2-point discrimination, for example. So even for those tools that we use in clinics, validity and reliability should also be established. And validity and reliability specifically are very important because it yields accurate and consistent results. So if I'm using an instrument that is intended, for example, to evaluate muscle strength or grip strength, for example, but this instrument is not accurate, it will affect the therapeutic process negatively, because it does not give me accurate results about the actual health status of my patient, and hence it misguides me whenever I put an intervention plan, for example, to work with my clients in order to, for example, achieve improvements in their health status to enable them to go back to be independent in their communities. And so validity and reliability establishes that the instruments or tools that are used in the clinic are accurate and they represent the actual health status of clients who come and receive health services in clinics. Because if they don't have problems, they would not have come to rehabilitation clinics in the first place. And it's extremely important to use valid and reliable instruments in clinic and in research as well.
Okay, so what's the type of validity? What's the name of it? Used when we want to correlate two outcomes that measure different constructs.
That's discriminant validity.
Okay. And there is a reliability test and retest question.
Yes.
Most research uses average of 2 weeks between the test and the retest. Is it acceptable to use longer times or shorter times? And what's
I think it's for test-retest reliability, the duration of time between measurements should not be long, because there are some improvements that are due to, let's say, spontaneous recovery or neuroplasticity, for example. So we want to actually do test-retest reliability without any potential confounding factors that may not yield accurate results. Because in test-retest reliability, as I said, the time is of an essence, and if the measurements correlate highly, whenever they're done at 2 different time points, they should, we can establish test-retest reliability. So I don't think that prolonged periods of time are recommended whenever measuring test-retest reliability, because other factors may hinder or may confound the results that are produced by the outcome measures.
So as a clinician and as a researcher, do you have to test and evaluate the validity of the tool and the reliability of the tool on all types? What is most important?
So content validity, if I were to choose what's most important, first of all, validity and reliability are validated or established through research, and clinicians can do research if they choose to. Second of all, if I were to choose what are the most important types of both validity and reliability, I would say that content validity is one of the most important, and the test-retest reliability is one of the most important in terms of reliability. So content for validity and test-retest for reliability. Okay.
For a test to be sensitive or specific, which is more important?
Both are important, but I think that sensitivity is more important, because it's able to correctly identify those who have the health condition or the disorder that we are aiming to diagnose or identify.
Okay. Okay. Can you explain us more about how to know the effectiveness of the results in the clinic? When can I say it's clinically important, not just statistics, but it's just clinically important?
Okay. So the minimal clinically meaningful change, as I said, is determined based off of the perception of the therapist and the patient. And minimal clinically meaningful change is the least change in health status that can be reflected on the actual performance of the individual. As I said, some of them have been identified or established for some health outcomes. Like, for example, for FIM, we said a minimal change of 22 points on the total FIM score is needed in order to say that actual improvements did happen in the health status of individuals whom we use FIM with. So, as I said, it's based off of the perception of clinicians and patients, and it can be some research studies did study that and identified the minimal clinically meaningful change for different health instruments. It could be maybe through correlating the change with the actual performance of specific skills. So, for example, if whenever evaluating the minimal clinically meaningful change for the motor subscale on FIM, they might use another measure of motor skills, then they correlate results on the motor assessment with the motor FIM subscale to see if the results are let's say, important or clinically significant?
Let's suppose I'm a clinical manager. I have therapists in my clinic, and I want to make sure they test the same way and to achieve the reliability and accuracy between evaluators.
Yes.
How should I do that?
My suggestion is to do a group session for training all raters on the administration of the tool in question. So for example, if you want to make sure that all your therapists use the same assessment tool consistently or accurately, you would group them together or bring them all together in a training session, and you show them how it is correctly done. If formal training is available or feasible, that's even better. For example, if you want to train your therapists on the use of functional independence measure, I suggest bringing an individual who is certified in the administration of FIM, functional independence measure. Then he does like this trained individual who knows how to administer FIM. Then he groups the therapists and he shows them or does a demonstration or a brief workshop about the correct administration of the functional independence measure in order to show them how it is accurately used for assessing patients. So training, to be brief.
Thank you so much.
Thank you, Dr. Muhammad. Thanks for everyone for attending and listening.